So again, thanks for coming. I have no ACCME disclosures. So there's a need for ongoing need to reassess prognostic markers for myeloma because the number of therapeutic options and combinations is always growing. A significant test for one regimen is later found to not be significant for another regimen. Also, therapeutic options are limited for some patients, so a prognosticator that's good for one patient may not be so good for another patient. It's really important before doing any testing to ask, will the results of this test affect patient care? And despite the fact that I'm somebody who makes my living from testing, I would say if the answer to this question is yes, then do it, and if the answer is no, then don't do it. When you do it, you want to know which is the best test method. And it's really important to understand that a lot of methods are really great for research, but don't work or they're not feasible for real-life diagnostic purposes. It's also important to ask how much does it cost and who's going to pay for it, keeping in mind that patients foot a larger and larger proportion of the bill. And studies have found that patients, for example, often don't want genetic testing. Cancer patients don't. So these are really important considerations. Until we have more precise targets or a better understanding of mechanisms, clinical features will, of course, remain the most important prognosticators: age, health, renal function, stage. But still, two patients that are in the same box based on clinical features will often have very different outcomes. And the reason is because their myeloma cells are different. So in addition to the clinical factors, we need prognosticators for tumor cell behavior. We need to know how fast are they growing and how fast and what therapy they might respond to. So genetics, gene array, genomics, these can often be used to give some information for the second question, but they're not good methods to assess proliferation. And to understand that, we need to just take a step back. So ask, if you're interested in the clinical behavior of a cancer, how would you investigate it? If you're interested in anything, how do you investigate? So if you're interested in a car, do you read the manual? Do you look at the parts? Or do you just take it for a drive? If you're interested in a sandwich, do you look at the list of ingredients or just eat it? If you're interested in a computer program, do you look at the code that was used to make the computer program, or do you just try it out for yourself? And if you're interested in your patient's cancer, do you look at the genetic code in the cancer, or do you just look to see what's happening? How far is it spread? How deep is it invading? And how much is it proliferating? So if you want to know the proliferation rate of your patient's cancer, you can look at lots of different cell cycle genes. You can look at tens of thousands of genes by gene array, or you can just look at one thing, which is Ki67. So if a cell has Ki67, it's proliferating. If it doesn't have Ki67, it's not. And often looking at all of the other upstream molecules can be kind of confusing and even misleading. So Ki67 immunohistochemistry is the best way to look for proliferation, but there's some problems with it when it comes to myeloma that hopefully we've solved. So there's multiple methods to assess myeloma proliferation. There's the old PCLI, there's gene expression profiling, flow cytometry, and immunohistochemistry. And immunohistochemistry, we've found, is the best way, and the reason is partly due to the fact that these other methods use a liquid aspirate, whereas immunohistochemistry is performed on a core biopsy with histologic sections. So why is it? Why is a core biopsy IHC the gold standard for determining the percentage of plasma cells? Why does the IMWG say you need to estimate plasma cells from a core biopsy and that flow cytometry should not be used to assess the number of plasma cells? Well, the reason starts, for the first reason is a liquid aspirate selects for just whatever cells happen to come out in the syringe, whereas a core biopsy is a complete intact piece of marrow that's truly representative of what's going on with the patient. So for example, if you assess numbers of plasma cells by different methods, this is what you see. So by CD138 staining of a core biopsy, which is the gold standard, these are in these, the black squares. These are the numbers of plasma cells. In these same specimens, if you count the number of plasma cells in aspirate smears, those are the yellow squares, you'll see a drop-off. There are fewer plasma cells in the aspirate smears. And then if you start to process the specimen for flow cytometry and count the cells again on a cytospin, the blue triangles, you'll see a further drop-off. And then if you assess the plasma cells by flow cytometry, the red circles, there's a massive drop-off. So what is the reason for this? Well, first, there's fibrosis. So in a normal marrow, reticulin fibrosis is limited to the area around vessels, whereas in a myeloma marrow, the myeloma infiltrate causes massive fibrosis in the area of the infiltrate. So if you stick an aspirate needle in a normal marrow, you'll aspirate out representative marrow. If you stick an aspirate needle in a myeloma marrow, you'll select for the uninvolved areas. So myeloma cells are underrepresented in about half of patients by about 20%, and lots of investigators have found this, comparing core biopsies to aspirate smears. So when you go from the core biopsy to the aspirate smear, the number of plasma cells drops due to fibrosis. But what about the rest of this drop? So in some of these patients, there were 100% plasma cells by CD138 immunostaining of a core biopsy, and less than 1% by flow cytometry. That's a massive drop. What's the reason for it? The reason is that myeloma is not leukemia, meaning myeloma cells cause fibrosis. They express lots of adhesion molecules, so they stick to each other and they stick to the stroma, so they don't come out very well in the aspirate. But more importantly, leukemic cells grow really well in liquids, but myeloma cells, as soon as you remove them from the marrow, they die really quickly. So if you take myeloma cells out in an aspirate, the relative percentage of myeloma cells drops over time, whereas the other cells survive. And it's important to note, if you have an aspirate and the percentage of plasma cells when you draw it, if you send it overnight to another lab, the number of plasma cells in the specimen when the lab gets it is going to be markedly reduced. Going from the gold standard, looking for numbers of plasma cells in a core biopsy, the numbers drop in the aspirate smear due to adhesion. They drop when you start to process the specimen due to ex vivo cell death. And then by the time you get to flow cytometry, there's a massive drop due to more cell death. Also, aspirated myeloma cells in a lot of ways don't represent the in vivo population. So for example, in this patient, by immunohistochemistry, you can see very clearly that the myeloma cells have really strong expression of CD138, and then the CD56 looked exactly the same. So massive expression of both these molecules, very clear in the core biopsy. In the flow cytometry specimen, in that same patient, the myeloma cells are here in pink. So by flow cytometry, the myeloma cells that clearly, strongly express 138 and 56, by flow cytometry, they're false negative. They're different, the cells that you get out for flow. And all of this leads to the sad conundrum that clinicians say we can't kill the myeloma cells in a patient's marrow, and investigators say we can't keep them alive in a test tube. So aspirates are best for leukemia and MDS. Core biopsies are best for lymphoma and myeloma. So why are we looking at this now? Proliferation assays for myeloma have been around for a long time. Well, one reason is that proliferation is a myeloma defining criterion, meaning that it reaches the IMWG threshold. So proliferation predicts an 80% probability of progression within 2 years. And the IMWG found that, but the authors decided not to officially include it in the list of myeloma-defining biomarkers yet because methods were not universally available. So what that refers to is, as recommended in the NCNN, there is the plasma cell labeling index. And this is a great test. It's been around since the 80s, and the PCLI showed conclusively that plasma cell proliferation is a really good prognosticator in all types of different myeloma patients. But the problem with the PCLI is it's not feasible for real-life use. So investigators have tried lots of different ways to make it fun to do, but it's really not fun. I can tell you it's really, really difficult in the lab, so it never caught on. So we wanted to know, is there a feasible way for measuring plasma cell proliferation for routine clinical use? So core biopsies are the best way to find plasma cells. What about immunohistochemistry? What's the problem with that? The problem is that with standard immunohistochemistry, you do a marker to find your plasma cells, and they look like this. And then on a second slide, you do a marker for proliferation, and it looks like this. And the problem is that you can't triangulate. You can't tell if the proliferating cells are the myeloma cells or the background cells with standard immunohistochemistry. And then the solution to this problem is multiplex immunohistochemistry. So by multiplex immunohistochemistry, you do Ki67 with a brown chromogen, CD138 with a red chromogen, use a blue counter stain, and then the slides look like this. So myeloma cells have a red ring around them. They're CD138 positive. If they're proliferating, they have a brown nucleus. If they're not proliferating, they have a blue nucleus. Very clear and straightforward. So this assay is called the Plasma Cell Proliferation Index, PCPI, and it works like this. Again, if myeloma cells will have a red membrane, proliferating cells have a brown nucleus, proliferating plasma cells have a brown nucleus surrounded by a red membrane, non-proliferating plasma cells have a blue nucleus surrounded by a red membrane. And this picture points to another problem with using aspirates to get data from myeloma cells, which is this. So if you take the myeloma cells and you crush them up and you do genomic analysis on this population, the data you get is going to be contaminated by all of the background cells. And even if you do a method to select cells, your selection is not going to be perfect. There's always going to be some degree of contamination. And if the percentage of proliferating myeloma cells is relatively low, and the background contaminating cells is really high, then your data for proliferation is not going to be good on aspirated cells. And then the good news is that any lab that does standard immunohistochemistry can do multiplexing. So if you have biopsies from your patients and you get immunohistochemistry, the same lab you already use can do this test. It's the same machines, it's the same commercially available reagents, it's the same expertise, and it's really easy to set up. So we did a really extensive laboratory validation. We made sure that the PCPI correlated with the old PCLI. And this is how it works. So you look down the microscope, you count 200 cells as either not proliferating or proliferating. So for example, in this specimen, the proliferation index is 30%, which is extremely high. It's very clear. We did clinical validation, starting with looking at transplant patients. It was a prospective trial following patients for more than 12 years, and PCPI was found to correlate with overall survival in the transplant population. We did a second clinical validation looking at newly diagnosed treatment-naive patients treated with standard induction. And PCPI is defined as low as less than or equal to 5%, and high is greater than 5%. By multivariable analysis, we found that PCPI is an independent prognostic indicator with median overall survival not reached versus 79 months, and progression-free survival 232 weeks versus 110 weeks. Also, in this study, we found that each 1% increase in PCPI was associated with a 3% increase in risk of progression. And there was a very clear difference between PCPI low patients and PCPI high patients among the newly diagnosed treatment-naive treated with standard induction. And then we did a third clinical validation where we looked at the effect of rising PCPI at relapse. So this was a retrospective cohort study of treated symptomatic myeloma patients. They had a PCPI performed at diagnosis and then again at relapse. And rising PCPI was described as a more than 5% increase at the time of relapse. 19 patients had rising PCPI, 17 had stable disease, and rising PCPI at relapse was associated with shorter overall survival and shorter progression-free survival. It's also important to note that if you're doing risk stratification, high risk by PCPI plus beta-2 microglobulin albumin identifies all high-risk patients, meaning that cytogenetics doesn't really add anything. That's what we found in this study. So here's the Venn diagram. If you look at PCPI as defined, or at high risk as defined by PCPI, beta-2 albumin, or high-risk cytogenetics, you'll see that all of the patients who had high-risk cytogenetics were also identified by the combination of PCPI, beta-2 albumin. In fact, there were 3 patients that were called high risk by cytogenetics that were standard risk by PCPI, beta-2 albumin. And among these 3 patients, there were some of the longest lived in the study. So that means there was a false positive by high risk cytogenetics. So we found that cytogenetics doesn't really add anything except for cost. And that's an important thing to think about. So it's important to ask yourself, what tests would your patient want? If you look at patient chat rooms, you'll often see discussions like this where the patients are saying, why can't I have plasma cell proliferation done? I'd like to have this piece of information. And that's because proliferation rate is really a tangible, straightforward thing. So with a lot of other prognosticators, like Raphael said, FISH, genetic analysis, they can be confusing even for clinicians. They don't really mean that much to patients. They can be confusing. But what percentage of your myeloma cells is proliferating? That's a very tangible feature that patients like to know. Also, it's important to ask, what tests would your patients be happy to pay for? So we already have studies showing that most patients don't want to pay for genetics. And then if you look at the cost of these assays, you'll see that cytogenetics costs upward of $1,000. Flow cytometry costs actually thousands of dollars. And then by comparison, the PCPI bill is $140, so it's very inexpensive. So other labs are now using PCPI for progression. We hope that it will be incorporated into the IMWG diagnostic criteria of biomarkers for myeloma. But the important question, again, just getting back to the first question I asked, is how would you use this piece of information to manage your patients? And if you think it would be valuable, do it, that's great, and if you don't. So thank you very much for watching.